مساء الخير عليكم. هنبتدي السيشن 4 اللي هي when hypertension is the hidden player. يساعدني كو-تشيرمان معايا الاستاذ دكتور باسم ظريف الفايس بريزيدنت اوف ناشونال هارت انستيتيوت، الاستاذه الدكتوره ساميه القاضي بروفيسور اوف كارديولوجي ناشونال هارت انستيتيوت، وانا ماجد رمسيس الهيد اوف ديبارتمنت. الدكتوره ساميه القاضي تقدم بريزنت فيرست.
I have the pleasure to introduce Professor Omar Awwad, medical therapy work for HFpEF.
صباح الخير my chairperson and my dear colleagues. المحاضرة النهاردة على heart failure with preserved ejection fraction, which become the main type of heart failure we are facing now. It represents more than 60% of cases of heart failure. The problem in the management of heart failure with preserved ejection fraction that we are treating this disease as a certain entity. It is more like a syndrome more than a disease. And because of that, we are not very successful in the management of the condition. And as we know, there is always when we are treating our patient, giving anything, we are comparing the benefit of giving that with the risk. And because we are using many drugs in this syndrome, the risk is high and the benefit until recently, it was not that good. The main line of therapy, which is very effective because we know that heart failure with preserved ejection fraction is a compliance problem. And because of that, diuretics is the most effective treatment because as we can see, it can improve the symptomatology and it can reduce hospitalization. So primary diuretics will be fitting in all the patients. And then this is the most effective line of therapy in case of heart failure with preserved ejection fraction. As we can see, it can decrease the cardiac preload by causing diuresis. It can decrease the cardiac afterload by decreasing the wall stiffness and increasing the endothelial function. And through that, it improves diastolic function with the main pathophysiological mechanism of this disease. And as we can see, that using sodium glucose transporter inhibitor can decrease hospitalization and can reduce cardiovascular death. And actually, this is now the main line of therapy of this condition. The second drug is the MRA, mineralocorticoid receptor antagonist, and the trial, which is the TopCat trial, was done in the States and in Russia. والغريب انها جابت نتائج كويسه قوي في امريكا وما جابتش في رشا. السبب في كده most probably the inclusion criteria and the methodology, and I think the actual result which we can take from the Americans. And as we can see again that the MRA is the second most important line of therapy in this condition. Again, it can decrease cardiovascular death and it can reduce hospitalization. So up till now, when we are facing a case of heart failure with preserved ejection fraction, the three lines is decongestion by loop diuretics, sodium glucose transporter inhibitor, and MRA. So it comes after that the drugs which is working on the renin-angiotensin system. And the ARNI, again, can be effective, and it is less effective than when you use it in heart failure with reduced ejection fraction, but still it has a role. And it can be effective both in males and females. When we come to other lines of therapy in the drugs working on the renin-angiotensin system, for example, the ARBs, as regards SHARM preserve trial, it caused a non-significant improvement in the condition. And again, the ACE inhibitor, as we can see in PEP with congestive heart failure, it can reduce the relative risk reduction by 37%. But I have to tell, زي ما اتفقنا قبل كده, in the main two lines up till now is the MRA and sodium glucose transporter inhibitor بالإضافة للdiuretics. السؤال هنا whether اللي ينطبق عليه the blood pressure we are needing in this condition, the lower the better. We can see from this meta-analysis is those patients with the systolic blood pressure less than 120 is worse than the blood pressure is higher. So you haven't to be so enthusiastic in lowering the blood pressure because this is not the best for them. The cause of that, those patients are, most of them are elderly and they are very liable to the risk of syncope and falls. And the cause of that, because of the baroreflex impairment, because of the increased ventricular vascular, decrease in ventricular vascular remodeling, the side effect of medication, and the decrease in the salt and water handling. And we should be very cautious when we are treating those patients in order not to lower the blood pressure to a certain extent. Other causes for the possibility of syncope and falls is the advanced age, which is present in most of those patients, the frailty, the abnormal gait, and the cognitive impairment. So again, we can add the line of therapy with drugs working on the renin-angiotensin system with the precautions that we have to be very cautious about the blood pressure level. Then we come to beta blockers. Beta blocker is not a drug of choice in this condition. And as we can see, there is no improvement whatsoever for the patient if you are giving beta blocker. Again, we can see with the difference in the ejection fraction that as the ejection fraction increase, as we are facing in case of heart failure with preserved ejection fraction, when the ejection fraction is more than 50, in this condition, it may worsen the state of the patient when you give beta blocker. But of course, there is compelling indication. If the patient is having ischemia, if the patient is having arrhythmia, you can give beta blocker. More than that, that stoppage of the beta blocker can improve the patient. As we can see here, it can increase the peak myocardial oxygen consumption and the percent predicted myocardial oxygen consumption when you stop beta blocker after diagnosis heart failure with preserved ejection fraction. And this is the results when you stop beta blocker. The quality of life improve, the myocardial oxygen consumption improve, the 6-minute walk improve, but the resting heart rate increase, of course, and the exercise peak heart rate increase. So beta blocker is not a drug to be used in cases of heart failure with preserved ejection fraction, except when there is a compelling indication for that. But we have to know that there is heart failure with mid-range ejection fraction, which is between reduced ejection fraction and preserved ejection. In this condition, you can give. You can give and you can have a good results when you're adding that to a patient with mid-range heart failure with preserved ejection fraction. And we can see in this group, when you stop the beta blocker, the cardiovascular events increase. Then the recommendation after the 4 lines we are speaking before, that beta blocker is not indicated except in a compelling indication, and we have to know that in mid-range heart failure it can be used. After that, other drugs which can be used, the statin. The statin, through improvement as a systemic inflammation, it improve microvascular inflammation and endothelial function, and all the trials show that when you use statin, all-cause mortality can be reduced, and again the MACE can improve. So statin is a line of therapy in this condition. And as regards dronedarone, which is an antiarrhythmic, it was proved that rhythm control in a case of heart failure with preserved ejection fraction is more better than rate control. And as we can see, when we give dronedarone in a case of atrial fibrillation, that we can decrease the MACE on those patients. So again, statin is a line of therapy, and dronedarone in a case of atrial fibrillation can be used. But the major change which will change the future of the treatment of heart failure with preserved ejection fraction, is what is called to move to phenotype-based therapy. We divided those patients whom are suffering from heart failure with preserved ejection fraction according to the phenotype type. And as we can see, we have many phenotypes. Those ordinary with just left atrial pressure more than right atrial pressure, those with high blood pressure and volume up, those with ambulatory exercise intolerance, those with pulmonary hypertension due to combined pre and post capillary hypertension, amyloids, heart disease, and hookah. Every single entity of this phenotype are now searching for a specific type of therapy to be effective on those patients. As we can see, for example, in hookah, the mavacamten, which is a recent drug working on the mitochondria, is very effective in the treatment of this condition. When we are dealing with inflammatory pathophysiological mechanism, the interleukin-6 inhibitor can be of benefit. Obesity and metabolic syndrome, the semaglutide is effective. And in case of right ventricular cardiorenal, the levosimendan. So we have to, if we need to improve the management of this entity of heart failure, which becomes the main type of heart failure now, this is the future. To divide the patient to different phenotypes and to give the specific medication to the certain type of, to certain phenotype you are dealing with. And I think this is the future for the management. And thank you very much.
Thank you very much, Professor Omar. Excellent lecture as usual. كنت عايزة أسأل حضرتك. Most of all hypertensive patients having HFpEF, okay? But some hypertensive patient, I have to give beta blocker because of high sympathetic tone. Patient is irritable, tachycardic, and essentially I have to reduce his heart rate. What do you think?
As we say, and the first slide, in every entity of drug we are using, we have to measure the benefit and the risk. So if there is a compelling indication, there is a certain type of arrhythmia, like you said, hyperpediatric state, and you cannot control it, except by that you can give it. But as a compelling indication, not routine, because all the studies prove that giving beta blocker in an ordinary case with heart failure with preserved ejection fraction is not effective, and it can be deleterious.
Thank you.
Excellent presentation, دكتور عمر. يعني أنا هيكونتينيو مع الدكتورة سامية دلوقتي. ال heart failure with preserved ejection fraction is very heterogeneous. So we can not يعني نعمم إن البيتا بلوكر، ولا سيما إن في دلوقتي special entity في الهارت failure with preserved ejection fraction called heart failure with supranormal ejection fraction. وده لما بيبقى فيه left ventricular hypertrophy وبيقل ال LV volume، الهارت بيتراي تو سكويز علشان يبامب the last point أو last amount of blood, and so it becomes supranormal ejection fraction, and the only effective drug here البيتا بلوكر. واحنا حتى من الفسيولوجي البيتا بلوكر بي prolong الدايستول، وهو الهارت فيلير of preserved ejection is mainly diastology dysfunction.
Let me simplify matters. If I am faced with a case of heart failure with preserved ejection fraction, my treatment now will be by diuretics, number one, because the main problem is compliance problem leading to increase in the end diastolic pressure, increase in the left atrial pressure, and increase in the pulmonary venous pressure. So diuretics. Then the sodium glucose transporter inhibitor comes number two, because all the experiments trials prove that it is very effective. والحقيقه ده دواء سحري. كل يوم دلوقتي بنكتشف ليه استخدام زي الاس انهبيتور اول لما شفناه. Number 3 it will be the MRA. As I tell you في العيان اللي عنده hypertension او العيان اللي عنده هوكم او العيان اللي عنده heart failure with reserved ejection fraction زي ما انت قلت الهارت is very stiff. There is a compliance problem. الناس دول اكتر ناس يحصل لهم deterioration لما يحصل لهم atrial fibrillation definitely لان they are depending on the atrial kick. If you are faced بعيان زي كده وعندك هارت ريت 120 وانت مش قادر تنزله طبعا وانا قلت ان هارت بيتا بلوكر is not a routine therapy but when there is an indication for that it should be given. Full stop.
Very, very ultra short question, please.
Thank you very much, Professor Omar. I think that the most phase for treatment of the HFpEF is the SGL2 inhibitor. For instance, that I have a patient is a slim patient, non-edematous, no hypertension. Why I use diuretic?
يا سعادة الباشا الباثوفيسيولوجي هو المتحكم فيك والدواء اللي تقدر تديه عمياني لان الناس دول 70% من 80% منهم بيشتكوا من شورتنس اوف بريس ديفينتلي والدايجنوزس بيبقى صعب. انت ما انتش متاكد ده يعني مش زي الهارت فيلير ويز ريديوس ايجكشن فراكشن العين قصادك فما مشخصه ده بيشتكي ويو هاف تو جيف ان ايفورت in order to have a specific diagnosis. طب ايه السيمتومز الاساسي؟ هو الديسنيا. الديسنيا دي سببها ايه؟ سببها diminished compliance, increase في left atrial pressure و pulmonary venous congestion. So you are giving the diuretic because of that. مش لان العيان عنده ورم.
Thank you very much, Professor Omar. Thank you.